The next speaker will be Christina MENIAS. She's really a leading expert on the abdomen, especially the area of kidney, bladder, adrenal, and retroperitoneum. She is a professor of radiology in the abdominal radiological section at the Mayo Clinic of the medical science in Arizona. This has a connection with the Mayo Clinics in the north of the US, and she joined the Mayo Clinics in 2013, so she moved over to the US, and that gave actually her exquisite experience. She was born in Cairo. She received her MD from the George Washington School of Medicine in Washington, so she's the combination of Egypt and United States. So we are really looking forward to your talk as an expert on the challenging GU cases, and challenging makes our work interesting, and that's what we like in our daily practice. So please show us what you think are the challenges of GU imaging. The floor is yours.
Thank you, Dr. Brents. It's very difficult to follow you and your expert lecture. That was just wonderful. This is part 2 of the GU cases for ACES. I did give part 1 on Zoom, and it should be recorded, and that was on the lower urinary tract images. And this is some interesting cases that are from upper tract per requests by Dr. Tarek, who I would like to thank for inviting me to this course. So my financial disclosures: I am a book author, and I am the current editor for Radiographics. So I do have that disclosure. So many of my cases you will see in the cookie jar cases on Twitter. All right, case 1. We have a 20-year-old male that presents to evaluate a renal mass. And you can see as we scroll through the kidneys, and we'll just keep going there. And just some still images with some coronal reformats of this young patient's imaging. And this is his follow-up ultrasound images from the right kidney above and images from the left kidney below. Remember, 20-year-old. And so we'll have a little bit of interactive. What do you think is the most likely cause of this renal finding? Is this a neurofibroma? Is this cystic renal cell carcinoma? Is this lymphoma? Is this lymphangioma? Good. So this is lymphangiomatosis or lymphatic malformation. You could see that there is extensive involvement in both the renal sinuses and the perirenal space. And it's believed that there is, just to remind us, that the lymphatic tissues surround the kidneys. And we see many times patients have this nonspecific stranding around the kidneys. We don't know what that means, nonspecific fluid. That's the lymphatics of the kidneys that are responding to something systemic in that patient. And usually the lymphatics around the kidneys communicate and drain through the lymphatic systems of the renal sinus. But somehow there's a block. And when there's a block of that drainages, they will develop parapelvic cysts. And indeed, many doctors do call extensive parapelvic cysts lymphatic malformation, because that is usually the source of that. You usually see perirenal low attenuation, fluid-like density, and multilocular in that. So the imaging here are 3 different patients with renal lymphangiomatosis. You can see that indeed there is perirenal, very low attenuation, fluid density associated with the parapelvic cysts. You can see them that can mimic a cystic nephroma, if you will. This actually went to the OR and deemed to be just a lymphatic malformation. This also was discussed and deemed as a cystic nephroma. You could see that it's actually looking like it's prolapsing into the collecting system, but was resected and proved to be a lymphatic malformation. Again, I just want to remind us that the perirenal space is the lymphatics, and tumor loves the perirenal space. Myeloma loves that, lymphoma loves it, but METs is one thing you want to think about that. So you want to really interrogate those images around the kidneys. That's actually tumoral deposits in the lymphatics of the perirenal space. All right, case 2. We have, let's see, I can't remember, he's a 55-year-old patient who presents with hypertension. And those are some still images of his upper abdomen. And we'll just show the coronal for that. I want you to keep your eye also what's happening on the left. And this is his PET scan. Indeed, there is something that's going on the right, but there is lots of activity on the left side and in the supraclavicular. So what do you think the most likely diagnosis in this patient? Is this metastatic pheochromocytoma to the retroperitoneum? Is this metastatic pheochromatoma with brown adipose fat activation? Is this metastatic lung carcinoma with perineural spread? Or is it diffuse lymphoma? It's a tough case. That's why it's a challenging case. Anyone? So this is pheochromatoma with brown adipose fat activation. So we call it BAT activation, that you could see that this infiltrative component on imaging correlates to the FDG avid uptake in brown fat activation. So it's believed that the catecholamines that's released leads to the stimulation of brown fat. And so this brown fat, as nuclear medicine practitioners know, does have uptake in PET-CT, and it has a potential false positive image. But you see that there's going to be other regions that are focally known with brown fat activation around the rib notches and in the supraclavicular space. I want to show you this case, particularly this one was quite impressive. This was a patient with metastatic. His primary was resected. You can see that there are multiple bladder-based pheos in the pelvis that have activation. But look what's happening around the kidneys. There's really nothing. There's no tumoral deposits, no soft tissue, but there's significant FDG avid uptake in this case. Here's another patient with metastatic pheochromocytoma. The primary has been resected. There's eclipse, tumoral deposits at the surgical bed, and you could see the uptake in the other regions of the perirenal space. And you have other areas, the lumbar vertebral body and the, again, the scaling site. So something to keep in mind that this may be seen in the setting of malignant paragangliomas or pheochromocytomas. Case 3. Very similar to what we just talked about. This is a 62-year-old male. He presents with what he says pain that shoots to the back of the head when he voids. So these are select images from his MR. These are T2 weighted fat SAD images. You can see at the level of the bladder that there are some soft tissue masses. Here's the diffusion and the correlative ADC. And these are the post-contrast dynamic images of these entities. So what is the most likely diagnosis in this case? Is this a paraganglioma? Is this squamous cell carcinoma? Is this schistosomiasis?